Okay, I think let's start. The name at first, good afternoon. I'm moderator of this session, and also Gabia will help me if there will be questions. She will pronounce them, and you will be able to answer them. The name of our session is Demographic Challenges I-Services. And I think the first presenter will be Violeta. I ask you because our presentators who had to present, they have difficulties, and maybe if they will be able to participate in our session, they will present the presentation in the end. Okay, our second presenter will be Laimutė Žalimienė, and her title of her presentation will be The Transformation of Care Work Under the Pressure of Service Users, Employers and Social Policy. Okay, Laimutė, the floor is yours. You can share your slides.
Okay, thank you. I will share my slides. Do you see?
Yeah, we see.
So I would like correct a little bit the title. My title is The Transformation of Elderly Care Work Under the Pressure of Users, Employers, and Social Policy. So I would like to do in such a way. Yes. The goal of my presentation is to discuss the changing structures of elderly care organization and how these changes have impacted upon those who work in the field. There are different conceptualization of care, of course, but in this presentation, elderly care is discussed as work or form of labor, which is tending to the needs of another. And this perspective lets us to interested in such issues as organization of care models, employment, or occupational well-being of workers. Many studies on the organization of care has focused much on the changing role of the care workers nowadays, and much attention is given to structures and processes of work, such as peculiarities of organizational models, marketization with the focus on cost effectiveness, tensions between professionalization and deprofessionalization. The framework of my analysis is visions of the future of organization of work and employment, which were suggested by Collins Williams, that there are multiple contrasting visions of the future of work. And such, for instance, as informal work will disappearing from economic landscape, or that formal delivery of goods and services will occur through the market rather than organized by the state using hierarchical model. What is variously called as commodification, marketization of economic activity. Or that this formalization, commodification of work will take place within a global economy or local economy, or about non-capitalist vision of employment, which is about more active participation of civil society in delivering of goods and services. Of course, there are differences across sectors and occupations in these visions. And for this presentation, it is important to clarify how these trends are envisioned, particularly in the development of elderly care policy and elderly care practice in general, and for using some examples from Lithuania, and what are the consequences of these developments for elderly care work and care workers. Talking about formalization, deformalization thesis in elderly care organization, the question is, do elderly care services will be organized through the formal providing or through the informal care providing? It is also the question about formalization, familization, defamilization policy. What may be arguments to support deformalization thesis? Studies envisioned that informal care constitutes a big share of elderly care, and the role of informal care very important in Europe still now. For instance, pandemic increases intensity of informal care and provide new insights that informal care may be more safe alternative in the case of disasters. Such instruments as cash for care vouchers, direct payments for carers and cared persons become important instruments in personal social services policy, which also reinforce informal care. For instance, in Lithuania, each year there are about 100,000 dependent persons who are receiving nursing and care allowances. By the other hand, availability of informal care resources for elderly in the future will decrease. It's because of changes in family structure, changes in living patterns, or because of emigration, like in Lithuania, when a lot of young people emigrated, and elderly persons will expect only formal care in the future. Of course, we may observe trends toward formalization of elderly care, which could be indicated by such indicators as increases in financing of in-kind benefits, introducing of a new innovative services for different vulnerable social groups. One more specific trend in formalization of elderly care work should be mentioned, and particularly is about attempts to overcome problems of undeclared or illegal care work in this sector. There are not exact data, but extent of it is significant. And for instance, the study in Germany shows that more financing for formal elderly care decreased number of informal care providers, talking about non-family infirm providers. But in general, public opinion about illegal elderly care work is more positive compared, for instance, about illegal work in construction services or in other economic activities, what also hinder problem solution. How these trends, formalization, deformalization, have impacted upon those who work in the field? What features of employment we can predict talking about formal employment? Studies show that expectation of potential service users is to receive person-centered, individual needs tailored, and home-based care, what indicate a need for development of various employment models, and especially non-standard forms of employment. What it means for working conditions, it means less quality of working places and less social protection for workers. For instance, domestic work is situated at the end of the care economy due to generally low wages, few benefits, and little protection. For instance, introduction of a new service and work position in Lithuanian, which is very important and much discussed in Lithuania, personal assistant for people with disabilities, means less protected working place, a quality of job problem within this sector in the future. Respite care, family and care reconciliation policies also support informal care worker, but also it raises pressure on family members to take care responsibility. For instance, long-term care policy in Lithuania focuses much attention now on quality of life of users, and it should improve quality of life of users. But much less attention is on quality of life of family care providers. Another vision toward care organization is about commodification, decommodification policy. Do elderly care services will be organized in the future using market model, or more suitable is hierarchy-based organization? Introduction of market model, which is variously called like commodification, commercialization, is based on expectations that market mechanisms will reduce public costs, increase quality of services, and increases user choice. But nowadays are seen and other consequences of these processes, such as incentives of employers to provide more services for the same money, not thinking about quality, or increase of workload. We can see support for deprofessionalization in the sector because less qualified labor force in care means lower cost for providing. There are studies that in market environment, social work became very bureaucratic. Organizations of personal social services became like fast food restaurants. And experiences in many years and in many countries led us to raise a question and discussions about do market model is the right model for personal social services, especially and looking through the lens of workers in the sector. Talking about Lithuanian practice and marketization, in 2006, the law on social services introduced a market model, but still the main model of providing is hierarchical model when municipalities allocate resources for providers directly. And there are not very much, for instance, private providers in elderly care in Lithuania. But there are increasing numbers of NGOs providers. The question is how marketization have impacted upon those who work in the field. For instance, such market instruments as cash for care means more demand for self-employed workers and in the same time less protected working places. And part-time employment, self-employment means less organizational support, less possibilities for improved qualification. A market model also increases the role of managers. Often the authority and control over organizational decisions have devolved from workers to users and managers, and some studies have been envisioned that the changes contribute to proletarianization of work, especially in such fields like doctors in healthcare or welfare work professions in social care. What are implications for elderly care work when talking about such trends as post-Fordism, post-bureaucracy, knowledge economy in nowadays societies? A shift from a post-industrial society to information or knowledge-based economy means increase of technologization in elderly care. According Bruno Latour, for instance, technologies become no less important actors of social reality. And robots can help to avoid heavily unattractive care work, and technologies can help informal carers to balance care and work. Talking about organizational culture, there are attempts to increase the loyalty of personnel, avoiding direct control of work, what is especially important factor of work motivation in such professions as social work. By the other hand, we can see trend to increase the direct control of workers by inviting technologies. For instance, municipalities and providers in Lithuania at least are exciting by using phone apps, which led to control working process in elderly care directly, not only working time in general, but by separate functions. For instance, how much time is spent on giving food or to give bath. This innovation in elderly care focuses much on economic effectiveness, on saving the time, working time, but there are no attention how it will affect work stress well-being of workers. Talking about organization of personal social services, they are not big in size. It's not mass production. But we can find nowadays pressure of private sector to become big elderly care industry because of economy of scale. And the term, for instance, silver economy, it's also like label of this trend. And if to go to some brief conclusions, if to summarize all this transformation from services users, we can see expectations for receive personal-centered, individual needs tailored home care, which means self-employment, domestic work practices, and low protection of work. Looking from the perspective of employers, when they provide services in the market, of course, there is focus on cost effectiveness, what means trying to increase workloads, deprofessionalization trends, increase of work intensity and stress under the technologization. From the social policy perspective, we can see global influences such as increasing of some social policy measures, cash for care, or quality standardization policy, technologies in work processes, what is also raises problems in occupational well-being of workers, devaluation of care as emotional labor, and consequently there are threats for relational nature of care work and care individualization. And briefly to conclude, multiple changes are taking place in the organization of work and employment in elderly care. And to address these changes, multidimensional social policy is needed. And integration of different fields of this policy, it means labor market policy, social services policy, family policy, are very essential. Thank you for your attention.
Thank you. My question is about alternatives to informal care. Yes, I understand that you evaluate good and bad things of that, but my question is about if it is possible to provide formal care for all who needed it. Due to aging of population. Thank you.
Thank you for the question. Of course, firstly, we should talk about which persons we can we can entitle to these services. It depends very much on social policy indicators. For instance, which indicators let us to provide services, less or more services for elderly people. And usually when social policy do not have enough resources for one or another services, there are some restrictions for some services. And in elderly care case, these restrictions may be like more pressure on informal care, more pressure for family, because formal care policy is not informal care policies. There are not enough resources to provide all these services. It means that this increase in aging population, increase and pressure for informal care, and not necessarily it means that social policy in the future will support more informal care providing. It's very controversial situation, and I think, especially when we talk about formal services, but also when we talk about informal care, which is now like on the focus of social policy, how to support, but support for informal care also needs money, finances, resources, and it could be complicated.
Yes, I have one question. You mentioned that elder care is insufficient and there is high pressure for family members to take care responsibility. So my question would be, how could it affect employment of family members, and how could you take care for elders if you work full day, have children? So how is it possible?
If to answer briefly to this question, of course, it is very important question, talking about employment and especially women's employment. And from my point of view, this pressure for informal care means that people who are working and trying to to provide care for family members, they will be more stressed. It means more stress, less quality of life for these people. And if to measure quality of life, people who have to reconcile family and work, we can find studies that it's a lot of stress for these families. And in this case, it means that pressure for informal care providers means more stress for these care providers and much less quality of life of this part of population.
Hello.
My name is Agota Vaitkienė, and I am a PhD student as previous representative Violeta Vilkaitytė at the Lithuania Center for Social Sciences. So I did this presentation with the moderator, Eugenijus Dunajevas. So if you have very specific hard question, please go to him. So the name is the accessibility of healthcare services in Lithuania. So why? During the pandemic outbreak, many people postponed their visits to the doctors because the whole healthcare system in Lithuania was focused on dealing with COVID-19 virus outbreak. So after a while, when the pandemic was officially over, all the people came to see the doctor, so it created some specific traffic jams in the healthcare systems. And it's a huge topic in the media. It was, at least for a while, that people need to wait for 1 month, 2 months, if you want to take your child to the doctor, sometimes 6 months, just to see the specific physician. And moreover, the accessibility of healthcare, like the ability to have access is very crucial, because sometimes if you don't have if you need to wait for a very long time, it can create more additional health problems. So we try to check this issue to see what is causing all these traffic jams, and maybe it's the problem from the government. And so on. So okay, so and it's very hard to take everything in our mind as researchers, because some of them are informal information, some are formal. So we try to focus on supply and demand factors affecting access to the services of general practitioners, because that's right. We have the system, tertiary healthcare system. So at first, a person should see the general practitioner or otherwise family doctor, just to get other referrals to see secondary or tertiary physicians. It's like the family doctor is a gatekeeper, and we can check the waiting time for the general practitioner, because people need to be registered at the clinic which is nearby, and all the other doctors, they can just choose freely. There is no rules whatsoever. So it's the data is very scarce, and like it would be too complicated. So that is theoretical background, and we made 2 hypotheses. One is from macro approach, that organizational deficiencies of healthcare institutions that lead to unmet patient needs mismatch between supply and demand at the level of Lithuanian municipalities. I should mention there are 60 municipalities in Lithuania, and they vary in size like a lot. And then we have hypothesis 2 from the micro approach, that patient behavior creates a favorable environment for queuing, that maybe the problem is somewhere else. Actually, we first made one hypothesis, then we failed, so we made another one, and then we checked again. So there are two different methodologies. So for hypothesis 1, micro approach, we checked data from Lithuanian municipalities. Because of the problem with queuing, the Minister of Healthcare, they decided to open for the public all the waiting times from all the clinics in different municipalities, that people could go in the internet to see for themselves how long should they wait in some specific municipality for a doctor. So because there are too many of municipalities, like 60, we divided them into 4 groups by the size, by the inhabitants. So the first one, the smallest municipalities, is up to 20,000 inhabitants, and the 4th group, the biggest municipalities, so it's mostly the big cities in Lithuania. All the others are more like regional. So it was data from the state health insurance funds on waiting times from 2022 February. And because we check general practitioners or family doctors in Lithuania, so the waiting times are a little bit different than other physicians. So it's 1 week, 2 weeks, or more than 2 weeks. We calculated an adjusted waiting time index. I cannot explain it. And then we entered data and calculated in Excel. And the methodology for hypothesis 2, we checked the data from the Institute of Hygiene Institute. It was from the Institute of Hygiene. It was the visits, and data from the state health insurance funds from 2022, the number of enrolled patients. So we tried to check if there is a correlation association between the number of visits and the number of average number of visits and the average number of enrollments. Like we guess that if there are many subscribers to specific clinic, there should be much more visits in that specific clinic. Like that there should be some correlation between the size and the ability to get to provide a lot of appointments. So analysis for hypothesis 1, macro. So we see only one correlation, which makes sense. It's correlation between demographic characteristics and queues. But the first group, the smallest municipalities, we see down because there was this issue with the smallest municipalities because according to the data which was provided, they have no problem at all. Like the efficiency is 100% and there is absolutely no queues for the family doctor, like at all. And therefore, we were thinking that maybe something is not very trustworthy with the data itself. But in considering the other quartiles, we can see that the trend line and the correlation, like they just match quite well. The correlation between population of municipality and queues in there is like, I don't know, no. Correlation between spending on healthcare services and queues in municipalities, there is also not very well seen, and the correlation between the number of treatment facilities with general practitioners and queues also, you cannot, I don't know, yeah, like this. So I don't see that it's very explainable. And then there is some match, but not Well, and then the average visits in 2022 and the average subscribers in 2022, it's like, it doesn't make so much sense. Like this data now is visualized, so it can be easily seen. But as we checked all the numbers, there were some very odd situation when the clinic is very small by the subscribers. But there is a huge amount of visits, a huge amount of appointments, and or the clinic is like very big, and there is a lot of visits and a lot of subscribers, but there is no direct correlation. Like we don't know how it works, because if there is not a lot of subscribers, usually it should mean that the clinic itself is very small. So it cannot provide with a lot of appointments, but like all these numbers sometimes just doesn't match. So we decided to dig deeper. We checked the data, but data was collected by the State Data Agency in 2019, and then we use the SPSS program to calculate everything. Like there is this data when people provide answers when and how they decide to go to see the doctor. Like what is the reasons for them to see the doctor, like demand factors for access to the services of general practitioners. And we checked a lot of factors, like, for example, sex, age, urbanization, also the health factors, chronic disease, blood pressure, depression, pain. There is a huge percentage of cardiovascular diseases in Lithuania, so we took this into account. There is a medication use, if people use some drugs or not. Also, the lifestyle, sports, fruit, soft drinks, smoking, and social network. So we took all these factors into account, tried to find the there is no visible rational strategy in order to avoid queuing. And the main not centrally coordinated. It may affect the overall accessibility of healthcare system in Lithuania. So the explanation that there is this bounded rationality theory, like if you want to act in a rational way, you need to have enough data to make the rational decision and then to act on it. And there is not enough data to make this rational decision while picking a doctor in order to avoid a queue. And people just don't try to strategize in avoiding queues. Like they do not think about the others. How will others behave in this manner? So everyone just tries to seek for a doctor because they have individual needs, and because doctors are ranked on online platforms and the health is the most precious asset for people, like everyone just made an effort to choose the best possible doctor, and then the queues is just unavoidable. And maybe there should be some specific decision. There should be some specific decision done by the government itself, because otherwise, when everything is very liberal, people just act on their own, on their own individualistic decision, and then it's just impossible to strategize. So, okay, I'm sorry if it's not clear. So thank you. If you have a question.
Does it work or not? Well, I can try to speak loudly. Thank you for the presentation. I would like to approach your topic from the perspective of the third country national in Lithuania. And first of all, to start that basically the access to the healthcare is quite complicated for the foreigners in particular, and for the foreigners who are coming from the non-European Union countries especially. Secondly, given even once you get access to the healthcare, then you get, for instance, appointment with a doctor after 2 months or after 3 months, which is, well, might be not the best case if you need some urgent assistance, right, or a SEP intervention. So basically, my question, given your findings also and the data that you went through, where perhaps it should be started in order to somehow improve slightly the overall access to the healthcare, and also keeping in mind that access to the healthcare is one of the essential part of the welfare system, and, well, basically one of the pillars. And I think eventually it also impacts on the way how the migrants or third country nationals or other foreigners overall find themselves in terms of the access to the healthcare services across the country.
Thank you for the question. So I didn't mention in Lithuania we have this universal health insurance that every person who works or studies, they pay compulsorily health insurance, and that we all have free access to the healthcare system. But it doesn't work very well in reality. We have like this social healthcare system, and at the same time we have this market, like the private medical care system, because the universal, the state healthcare system doesn't provide people with enough healthcare services. So there is a possibility for a person to go to the private clinic and to pay for the appointment, and there is no need for referral, for example. So people who migrated into Lithuania from not from European Union countries, they are dealing only with this. Sometimes they can only use the private sector, or if they are working officially, they should be able to see the public healthcare specialists. But we all deal with the same issue, that it's very hard to get to the doctor, and there is like so many informal ways people are using to do it, but it's like another topic. And there is a huge problem in, according, like Lithuania is a welfare state, I don't know, but there is not enough funding to the healthcare system. Like, and doctors are talking about that a lot, that their salaries are not big enough, or that there is not enough money to provide everyone with medication or healthcare services. Of course, it's not so bad, like it's not very bad, but the efficiency is not good enough. And so there is this, people try to push government to expand spending on healthcare services in Lithuania. And there should be some, for example, right now, private and public healthcare services sometimes use the same system, the same insurance money. And there is no strict division between these two parts. So there is some mix in it. And people who pay compulsory health insurance and they go to the private sector, they still need to pay for the appointment if they use private healthcare service. And for example, they still can get the money from the government, even if it's a private sector. They just need to have an agreement with how you call valstybinės ligonių kasas. Like the system is a little bit mixed, and there is we can see that there is some that the healthcare services are going to the private market, like there will be privatization or something like that, that people who will deal with public sector, they will get poorer healthcare services. Just that. And so migrant, they are part of the problem, like they are dealing with some issues, but the problem is much bigger than just how to integrate immigrated people.
Thank you. And another question?
Thank you. It's really a hot topic in Lithuania, and actually I continue what we started to talk. And a couple of times, I'm from Lithuania, living here, and a couple of times I was in this situation when you are putting in the line for 3 months, and actually you could even die through this 3 months. So my decision was to use this private sector, and there is an interesting thing that in the private sector I meet the same doctor that was in the public sector. So if you could pay money, you could get this consultation even next day. But if you don't have money, you get this consultation after 3 months. Don't you see inequality of healthcare here?
I think the inequality is huge, and it's getting bigger. And also, I should mention that I'm a daughter of a doctor. So, if I would like to, I can get to see every doctor I need without even paying, because there is so much informal structure in it. Like my PhD thesis is on residency, so it's I hear a lot myself, and I know from my personal experience that like people who work in hospitals, they usually don't use the official circuits to get to see a doctor because they can arrange the meeting on unofficial times and so on. And it is inequality too, but it's very like there is this tradition, like historical tradition, even from Soviet times, I think.
So you don't have these ways. What you should do?
Well, there is this. I don't know. I'm very worried about. I'm very worried about people who are in rural areas, or because hospitals are closing down and the infrastructure itself is not very well organized. And sometimes it's very hard just to get to the hospital, especially if you are, like, for example, old or you have a lot of children. Like, it's very hard just to see the doctor. And they try to make some changes in the Minister of Health. They talk about telecommunication, about this, that you can arrange this emergency drive and so on. But there you should have some money for it. And I don't know. I don't know if you are just a poor person or just person without any connections. I have no idea what you should do. And I think people, then they use just informal ways how to heal. Like there should be a growth in this paradoctors. I don't know how to say, like this people who know how to heal something, but they are not officially doctors themselves. Like because it's so hard to get to the point to see sometimes, because they can choose like this system is focused on people who can pay money. And so if you have money, you can, but if you don't have enough money, because health is very expensive, especially like I can talk about teeth, about dentists, like it's privatized, I don't know how to say, long ago. So it can cost 2,000 euros just to fix your 2 teeth and so on. And people who don't have this money, what can they do? Like this is a huge problem. Yeah, I don't have an answer what to do. Like, but that a huge problem. But not only in Lithuania, it's really like global problem. The inequality seems to be growing in this perspective. A very depressing note. We can finish.
One more question. That is the last question. Okay.
Thank you for your presentation. And I don't know, is it your study field, health sector? Because my question is about telemedicine. Because as I heard, it started in Lithuania some years ago, but it is a really great tool to increase the efficiency of health sector, but it's not working in Lithuania. And as we're hearing abroad and also in private sector, it works, but not in our public sector. Maybe you know the answers?
It can be related to data security law. How to say BDR?
Yes.
It can, because the technology is there. And people should use telemedicine. Like there is this project, like if you are in a rural area and you go to the rural hospital, they connect with the main clinic in Kaunas or Vilnius, and they can arrange appointment, like to consult with a specific doctor, with a specific specialist on this topic, and they can have this connection. Like they can talk and they can send the MRI pictures or like X-rays pictures, but if it's not working, it can be based with laws, because there is very strict security regarding the private data, and all the health data is private, and it should be protected. So probably they just need to imply the law and then they can provide, because otherwise the punishment, it's very huge. Like there is a lot of money in it, but because I think the technology is there, like, or if there is not, so they just need to buy some stuff and to send it to rural areas, and that's it. But it should be, maybe there is a lack of political will, or maybe there is a lack of political will in administration of specific healthcare institutions. Like, because as I'm doing my research for my PhD about organizational work culture in public hospitals, Lithuanian hospitals, they have quite a lot of autonomy in deciding what to do in the hospital itself, like how to apply and what to apply. Like there is no, the minister or like, I don't know, the government doesn't have so much power on forcing a specific hospital to imply some specific laws or details. Like there is a lot of, like, it's like with universities, like university has a lot of autonomy. So it's well, it's very complicated systems.
Thank you. We have our last presentator, Līga Rasnača. Sorry if I pronounce not well. The title of presentation is Social Welfare Specialist Between Local Challenges and Local Situation.
Yes.
Yeah.
Yeah.
Right. Ah, okay.
Thank you for listening to me, because I'm sorry my voice is not in good condition for presentation today. So let us go through that. Previous presentation was very interesting, and in Latvia situation is even worse. Speaking about the healthcare system, but it's for other time. So what about my today presentation? I have compilated this presentation from two studies. One is finished, but other is in process. Which is in finished is about consequences of COVID-19 for social work and especially for social interaction in social work, how it was changed. And other is about what is feelings and understanding of social work with Ukrainian refugees, because this also is something new for Latvian social worker, as well as COVID was something new. We haven't met such a pandemic, and both these cases could be global challenges according United Nations definitions. Yes, the issues that transcend national boundaries and cannot be resolved by any one country acting alone. Yes. And of course, there are goals of which are very important also for social policy and social work, as human rights, international justice, and so and so. Challenges also have some dimension of time, and we could look at that as current crisis. We could look as risks to be most severe in some 2 years, and risks that are likely to be most severe in 10 years. And if today we were discussing issues about aging, that means in 10 years and maybe even worse in 20 years, and also healthcare issues. So, of course, and these issues are not only for one country, they are globally important. Which organizations I was looked at United Nations and World Economic Forum, because they have done a survey about global risks perception and included 12,000 business leaders from 121 economies or countries. And as most expressed issue, they said it is cost of living crisis. Of course, cost of living touch each dimension of welfare. Second is natural disasters, and third is geo-economic confrontations. If COVID-19 was linked with cost of living, but mostly with weather, health conditions. Ukrainian war is linked, of course, with geo-economic confrontation. And I place in my presentation this picture from World Economic Forum. And why I placed it? Because there we could see different types of crises and challenges, how they are mixed together and influence each other. It's not my authority, but sources this World Economic Forum. Of course, I looked also at EU because we are EU member state, also Lithuania is an EU member state. And which priorities EU named as strategic priorities. Climate change and biodiversity loss. Second, the global response to the pandemic, our COVID case. And third, response to conflict that cause harm to civilians and threaten global security and stability. Ukrainian case, yes. Also, International Federation of Social Work pay attention as well to COVID-19 as global problem, but also they pay attention to Russian invasion of Ukraine, but International Federation of Social Work mostly pay this attention in European section as regional event, not so more as a global event. But of course, for our region, it is very important issue. Methodology. Global challenges affect social workers on several levels. And macro level, global, national, meso level, organizations, institutions, I will not touch this meso level today. And micro level, social interactions. About that, I have some data. About global level, I use secondary data, but about micro level, I use data from semi-structured interviews with social workers, and data from 52 interviews were analyzed, and these interviews were conducted from 2021 till 2023. There were more interviews, but not all touch these issues, especially Ukrainian case, because 21 they not touch because these interviews I was not using. Theoretical background. When we do this study first, we try to find different theoretical approaches, but to my mind, the best one was heuristics. This term describes adaptation process in contrast to rationality. It implies a simplification of decision making. Because in complex situations, when in new situations, in situation when we met with new challenges, social workers need to react to that, but it is not possible to do that according long instructions due to do all bureaucratic procedures and so on. It's impossible. I have analyzed how many documents were issued from Ministry of Health and Ministry of Welfare in Latvia, and it takes time, some 2 weeks to read them all. Yeah, of course, no from practitioners have not such time. So there was simplification and orientation in situation. And why COVID case was so difficult? Because everyday interaction, conversation, and so on, social workers use also non-verbal communication, and it is very difficult to include this information in written form. When there was distancing, then there were not possibility to interact face to face. It was very, very difficult. And of course, it was very difficult also in communication with service users, especially with such risk groups as disabled people, as older persons, and so on. And of course, digital transformation was rather strengthened in this time. Yes, we started to use more different programs, applications, and so on, but that also excluded some parts of society. Those who have not availability of such instruments, and who have also not resources for that. So I have mostly mentioned. If you have some questions, then ask me, and I will go to other case. Refugees from Ukraine. There are little bit controversial data, but not in very details. In Europe, there were recorded, as I looked at EU, almost 6 million persons, and there are little bit differences from United Nations Refugees Agency and from EU, and differences are that globally there are recorded 6 million refugees from Ukraine, but beyond Europe there are 2 million. But this is a little bit different statistical systems, and they have a little bit controversial data, but not in very great scale. And there are map from EU Council, and there you could see Germany and Poland, Lithuania and Latvia. And for our population, also this number of refugees are important. For Latvia, we have 1,800,000 inhabitants approximately, yes, and we have more than 42 refugees. Lithuania have 77,000. More than Latvia, but you have also more population. And after re-establishment of independence, it was first time when we really have get with such problem as refugees coming from war, from real war, and not only for economic issues. It was rather interesting that we have one guest lecturer from Germany, and he was a little bit wondering that Ukrainian refugees are not so interested in benefits as other refugees. They are really seeking for security. Social work with Ukrainian refugees. This is not finished part of this study. What social workers said about interaction with refugees. There are two main factors. One is how to work with people who have gone through crisis, who have some losses, who have some very tragic events in past and so. And other of course, is problem with language. And in Latvia, we have rather an important part of population Russian-speaking, but among Russian-speaking, there are also rather important persons who are in part of Russia, not in part of Ukrainian. So there could be problems also in social welfare systems. We have not conflicts in social welfare system, but we have some cases in judicial system. And also social workers noticed that it is essential how information is linked with refugees. If they have sources for information, they trust, because it's not necessary this formal information, but trustful information is very, very, very important. Of course, in all situations, this age, gender, experience are very important and individual approach. Conclusion. Most important global challenges for social workers in Latvia during last 5 years were COVID-19 and war in Ukraine, respectively refugees. The different groups of service users have particular difficulties, and social workers have to adjust to each kind of difficulties. Social interaction have changed significantly during COVID-19. Remote work, use of different applications and programs, and so. And social workers' skills, how to communicate with people who have experienced suffering, losses, is significant working with war refugees. The language skills are necessary instrument in performing social work with refugees. And heuristics could be applied as theoretical background, analyzing shifts in social workers' communications, occasion meeting people suffering from global challenges. Thank you very much.
Thank you.
Thank you for your presentation. My question would be actually with regard to the social workers in Latvia. Do you have on the national level, on the regional, on the local levels, some sort of programs or trainings or any other activities that would aim to build up the expertise and the, let's say, qualification that would be aiming to make them even more professional and more advanced in terms of the providing of the different types of services?
Studies master level system, master level studies, and some are studying in doctoral level but not yet finished. It is in contrary with Estonia, where there are, to my mind, more than 30 or maybe 40 doctors of social work. We in Latvia have one. But of course, we have also how it is professional education qualification. Yes, and this system is rather good, but it is on the project basis. It is financed on project basis. Through EU projects, through support from welfare ministry, and we also have summer school programs. For example, this summer we have summer school about community work specialization. So different specializations for social work is not only from universities, it is also education after graduation.
Thank you for your presentation. Then we heard a lot of challenges of social workers. And my question is, what do you think about future, about artificial intelligence? Because I imagine that it can be another crisis for social workers. And I don't know, maybe I want to hear your opinion.
About artificial intelligence, we have challenges in universities with that course. Because we need to do more deep analysis of each essay, each work, to look how it is made. And so in social work, of course, artificial intelligence could help, maybe. But this face-to-face interactions and also emotional support we can't find from artificial intelligence. Yes. So I think that social work profession will be needed also in time when artificial intelligence will do more operations than now. Thank you.
May I ask?
Yes.
Sorry, may I ask?
Can I ask it? Yes. Yes, you can.
Okay. Thank you for interesting presentation. And my question is about could we say that such global crisis like COVID, war in Ukraine, envisioned the need to go out of national traditional frameworks of services providing? And do the legislation was an obstacle to react to provide social support in the new context in Latvia? And do you think that strong regulation of social work, particularly of social work, social services, maybe it's not a good case in such context when there are a lot of changes and you need to react quickly to these changes? Thank you.
Thank you. Of course, always is problem to react more quickly. But I think that Latvia reaction to Ukrainian war was rather quick and support, of course, firstly, the support was, I don't remember, for 3 or 6 months and so on. Now it is for 2 years and maybe it will be prolonged, yes. But the problem is that even if these national level reactions are rather quick, and this in Ukrainian case it was rather quick also in EU and in Latvia, the problem is to react in local places and for each individual, because it's not possible to prepare, for example, social workers in our border regions as Alūksne or Balvi, how to meet those refugees, because there were also not all refugees coming to stay in Latvia. Many were coming to go through Latvia to Sweden, to Germany, but they also need some support because after some days in car and some medical support and so on, yes. And there were voluntary groups in such situation, and volunteers, of course, it is one of ways how to solve such situations. Speaking about COVID, in Latvia, this COVID firstly was rather not so important. After that, numbers was going up, but in first period in Latvia, it was more as threat and formal case and bureaucratic case, not real. So till now, in society, there are rather contradictory attention to government instructions during COVID, and also even among social workers. For example, in our interviews, there were social workers who said it's not social work if we can't meet with service user. It's a parody from social work. It's not real work, and so. If I try to answer if it's enough.
Yeah, thank you.
Thank you.
Thank you. Okay, now our session is over, and we now will go to coffee and sweets and something. I don't know what else there should be. Okay. Bye. Bye. Bye.